Now we're going to get into immunity. We're going to begin with innate immunity in chapter 6. So we discussed in the last chapter how there are many things that damage us and our cells. We talked about sun, pollution, physical trauma, unintentional and unintentional wounds. We talked about infection, damages that can be done from the inside with things like cancer. We also talked about damages that can be done on the cellular level in our tissues and our organs and ultimately cause disease or death. So what we need to talk about now is what our body does in response before things go too far to the point of death. This is when the immune system steps in. There are several ways in which the human body does protect itself. We have mechanisms of response. In the first response, we have what's called innate immunity. What's important to know is that our innate immunity and all that it does is present at our birth. It is essentially the first responder. It provides the initial response to invasion and injury on our body. The innate immunity provides natural, physical, mechanical, and biochemical barriers, which we'll go over. These things work together to prevent damaging environmental threats and infection. So whatever is trying to get us gets past this first line of defense, that's when we see the second line of defense kick in. This is called inflammation or the inflammatory response. I want you to know that inflammation, importantly, is a part of innate immunity. When we think of inflammation, what symptoms do we think of? Redness, swelling, heat. This response further protects the body from injury. It fights infection and it promotes healing. We then have our third line of defense. This is another type of immunity, our adaptive immunity. It's also known as acquired or specific. This type of immunity has a little bit of a more specific process when it's fighting the bad guys. It targets particular invaders and has the sole purpose of getting rid of them. Adaptive immunity actually involves a working memory. So if the same invasion happens, there's going to be a more rapid response because that adaptive immunity has already fought them, it remembers, and it knows best how to defeat them. In this chapter, we're going to focus on innate immunity and inflammation. So again, in this lecture, we're going to focus on the first and second lines of defense, our innate immunity and inflammation. Again, remembering that inflammation is part of innate immunity. Remember I said the first line of defense involves physical, mechanical, and biochemical barriers. So let's go over these. The physical barrier is considered the skin, the integumentary system. This physical barrier offers a huge amount of protection from the outside to ward off tissue damage and infection. This barrier is made of tightly woven together epithelial cells. It includes the linings of the GI, the GU, and the respiratory tract. What happens here is when pathogens try to invade this first line of defense, they are more than likely going to be removed by mechanical means. So what do I mean by mechanical? Here, pathogens may slough off with dead skin cells. In the respiratory tract, they are removed with mucus that the cilia of the cells have moved up and out of the body. That triggers the cough or the sneeze to get rid of them. They are removed out of the GI tract by vomiting or defecation and are removed from the urinary tract with urination. The temperature of our skin, which is relatively low, and the low or acidic pH of our stomach also does not allow for pathogens to hang around. Cells also participate in this mechanical removal of pathogens. These are mechanical barriers, in other words, chemical barriers that act to remove pathogens. So we know that cells secrete mucus, sweat, saliva, tears, earwax. All of these things trap the unwelcome guests, the pathogens, and break them down with lethal force. Sweat, tears, and saliva, they actually contain an enzyme called lysozyme. This enzyme attacks the cell wall of gram-positive bacteria. Our sebaceous glands, they secrete a fatty acid and lactic acid. This also kills bacteria and fungus. They also cause the skin to have that acidic environment. Usually our skin is at a pH of about 3 to 5. Most bacteria cannot live in that condition. Epithelial cells, they also secrete antimicrobial peptides. Remember, what are peptides? They're made of amino acids. They are the building blocks of our proteins. These peptides will kill and inhibit growth of bacteria, fungus, and viruses. Two examples of these are called our defensins. These are produced by neutrophils or white blood cells, and epithelial cells. Defensins down the membranes of the bacteria. There are also what are called collectins. It's important to know that collectins are made by our lungs. Surfactant, the stuff that keeps our lung alveoli open for better breathing, is made of collectins. These are considered glycoproteins, and they send macrophage. Macrophage is actually Greek for large eaters, to recognize and kill the pathogens. Lastly, the first line of defense contains a biochemical barrier. This is considered our normal microbiome, otherwise known as our normal flora, the good guys. They live in parts of the anatomy like the gut, the skin, the nose, the mouth, the vagina, the urinary tract, many different places in the anatomy. The flora is unique to the area it is in, and they have what's called a commensal relationship with us, which means that the relationship benefits them, but it doesn't affect us. They're not causing disease. Rather, they're helping us in many ways. Our bodies tend to create a safe space for them. So what is it that they do for us then? They produce enzymes to aid with digestion. They synthesize metabolites like vitamin K and vitamin B. They release pathogen-killing antibacterial substances like ammonia and phenols, and they will fight the pathogens for nutrients so they thrive and the pathogens die. And they also won't allow the pathogen to attach to the epithelium, which is what happens in the first step of infection. They help to build our third line of defense, the adaptive immunity, which we'll talk about in the next chapter. And lastly, they help communication between the gut and the brain, also known as the brain-gut axis. Many things are associated with this axis. Cognitive function, stress response, and disease are just a few. One last thing that is important to know here is that sometimes these normal flora can go rogue and become what is known as opportunistic pathogens. As discussed previously, they're usually harmless, but if someone is immunocompromised, meaning that they lack regular defenses, these pathogens can become insidious and take hold. An example is if someone is severely burned. The skin integrity is severely compromised at that point. So normal bacteria that live in the skin can take advantage, enter this bloodstream where they don't belong, and cause a life-threatening systemic infection. Now let's get into the second line of defense, inflammation. Again, we're still talking about innate immunity here, but know that inflammation happens to protect the tissues then from infection. What is happening here is that when tissue damage occurs, there is a release of inflammatory mediators, the good guys. Mediators are things like leukocytes. What are leukocytes? They're white blood cells. Mediators can also include plasma proteins and other biochemical or chemical components. These mediators move from circulation into the tissue. They kill pathogens, try to limit the damage, and begin the healing process of the tissues. Inflammation is a programmed response, and it has certain characteristics. For one, the tissues have to be vascularized or have a blood supply. Know that inflammation also begins within seconds of the damage occurring. Inflammation contains cellular and chemical components. And importantly, it is non-specific, meaning that it takes place in the same way regardless of what type of injury we have and whether or not it has happened before. For example, a splinter is going to have the same inflammation response as a cut. And no matter how many splinters we get or how many times we cut ourselves, the inflammatory response is going to be the same. Let's dive a little deeper into the vascular response of inflammation. How do our vessels respond? Remember that vascularization means that tissue has a blood supply. The response of inflammation can be triggered by many things: infection, ischemia or lack of oxygen, trauma, physical or chemical injuries, foreign bodies, and immune reactions. So I asked earlier, what are some of the signs of inflammation? The signs of inflammation were first described by a Roman named Celsus, and on page 136 of your book, it gives alternate original names of these symptoms. But essentially, we would see redness or erythema, heat, swelling, pain, possible loss of function. All of these things are happening because of inflammatory changes on the microscopic level. While we may also see fever, what I want you to know about fever, that alone, it's a systemic response. It's not a local response like the redness and swelling and pain. So what I mean by systemic is that it's involving the entire body. Here, we're talking about the local responses again. So locally, these inflammatory changes are going to include hemostasis or coagulation. If a blood vessel is injured, the clotting cascade, which we're going to talk about, is initiated and platelets are activated. The clotting is going to slow blood flow, build a wall around the injury, and provide a base for healing. We also see vasodilation with inflammation. This literally means that the vessel dilates or gets bigger. There's an increased diameter in the vessel. It's going to allow for more blood to come through to the site of the injury and slows the speed of the blood flow. This lower blood flow allows more time for fluids, chemicals, and cells to get to that damaged tissue. And this is what happens when we start to see redness in the area of the injury. When I say increased vascular permeability, that means that the blood vessels are becoming more porous. The endothelial cells of the vessels contract, and there's bigger spaces because of that in between the cells. This is going to result in what's called exudation, or the leaking of fluids from the vessels. This results in the edema, in which tissue swelling is happening from the fluid leakage. It is important to know why we will see this edema or swelling in the area of the injury. So no, it's because the vessels start to leak. We also need to talk about the important work of the white blood cells. These are going to attach themselves to the inner walls of the vessels. They also get through those enlarged spaces between the contracted endothelial cells of the vessels. Large amounts of phagocytes, which are made up of neutrophils and macrophage, get into that tissue and target pathogens. We're going to talk more in depth about white blood cells as we move on. So what are the protective functions of inflammation? Even though inflammation can produce pain and limit function, it's going to prevent infection and limit further damage from the pathogens. We see this when the exudate or fluid from the vessels dilute and wash out toxins. The clotting system contains and destroys, and the phagocytes remove toxic cellular debris and pathogens to prevent them from further harming us. There's also limitation and control of the inflammatory process. With the clotting system, the plasma enzymes, they only respond to specific blood or tissue cells. That means that the inflammatory response limits itself to the damaged tissue only. Another protective function is the preparation of healing. Here, the removal of bacteria, microorganisms, dead cells, and other debris is going to set the stage for good healing and repair. And lastly, it helps the development of the adaptive immunity, the third line of defense that we're going to talk about in the next chapter. As that debris is removed through the lymphatic vessels and nodes, pathogens encounter macrophage and lymphocytes that would recognize their return. So to have a proper inflammatory response, there are three key plasma protein systems. This is the complement system, the clotting system, and the kinin system. Each system has a unique role, but they may seem similar to you as well. All of these systems have proteins and enzymes that are inactive circulating in the blood. When tissue damage occurs, they're activated, and they initiate a sequence. This sequence is usually referred to as a cascade. That's important to know. So when we talk about these things, you may hear something like complement cascade or clotting cascade or the kinin cascade. So the complement system is the first one we're going to talk about. And I know these systems can be somewhat confusing. So I did post a video under this chapter for you to watch if you are needing some more visuals and more information regarding the systems. But the first one we're going to talk about is the complement system. So what it does is it helps antibodies and phagocytes clear the pathogens and the damaged cells to begin to activate inflammation. So this complement system, it has a large number of proteins that circulate in the blood. When damage activates the system through pathways, which we'll talk about towards the bottom of the slide, proteins are going to produce several substances. These substances are going to kill the pathogens directly or kill them by helping other components of the immune response. A big part of the complement cascade and its process is the activation of the specific proteins C3 and C5. Release of these two proteins facilitates the work of three important molecules as part of this system. Opsonine molecules are going to coat the surface of the bacteria. They basically tag them, making them vulnerable for death or phagocytosis. Chemotactic factors through chemotaxis, which we'll talk about, they act as a magnet, attracting leukocytes or white blood cells to the site of the damage, basically calling them over. And anaphylaxis toxins, these work on mast cells. These are a type of white blood cell. They help to release histamine. Histamine helps us vasodilate and increase our capillary permeability, meaning making those vessels bigger and making the gaps so that bigger items can fit through the vessels to start that inflammation process. So there are pathways. This C3 and C5 have three different pathways that control the activation of this complement system. In the classical pathway, antibodies are activated. What do we know about antibodies? These are blood proteins that are made in response to an antigen. Antibodies are actually a component of the adaptive immune system of the third line of defense. So we're going to talk about that in the next chapter. But here, antibodies are going to bind to proteins and carbohydrates that the pathogen has made, also known as antigens. In the lectin pathway, plasma proteins are going to bind to the polysaccharides of the bacteria, which are going to activate the complement system. And then in the alternative pathway, the endotoxins that are found on the surface of the microorganism that is infectious will activate the complement system. The clotting system is also known as the coagulation system. It is the next plasma protein system that goes hand in hand with inflammation. When this is activated, it is activated again in a sequence or a cascade to form a blood clot. The clotting system is usually activated by a variety of substances, things like collagen, enzymes, or bacterial toxins, all of which are released during tissue injury or infection, telling that clotting to cascade to begin. So what is a blood clot? It's meshwork. It's fibrin, protein strands, and platelets to make it up. Clots essentially serve to plug damaged vessels and stop the bleeding. But as we said earlier, inflammation does limit itself to remain in the area of injury. So clots are going to help this. They're going to trap microorganisms and prevent their spread to adjacent tissues. Clots essentially set the framework for healing. Here we're going to see two pathways that could lead to clot formation. In the first one, the extrinsic pathway, tissue thromboplastin, this is an enzyme, is released by endothelial cells of damaged blood vessels. This reacts with a factor. Factors are protein that causes the blood to clot. So this particular one reacts with factor 7. I had to count. 7. And that is a protein that causes the blood to clot. In the intrinsic activation, which is otherwise known as contact activation, the vessel wall causes a release of a substance that comes into contact with Hagman factor or factor 12. This is another protein that is found in plasma, another clotting agent. Both of these pathways are going to end up at factor X, which is another protein, forming then the common pathway. This then will lead to the activation of fibrin, and the fibrin will come together with the platelets to form a fibrin clot. The third plasma protein system is the kinin system. This system works closely together with the clotting system. They are similar that they can both be initiated through the activation of the Hagman factor. Remember I said that that's a protein. The kinin system activates several components in the cascade until the final product of bradykinin is released. Bradykinin also causes dilation of blood vessels, and it works with prostaglandins to induce pain, trigger smooth muscle cell contraction, and increase vascular permeability, all parts of inflammation. The three plasma protein systems are highly interactive. One system may produce something that triggers another system. It is essential to know here that there is a tight regulation of these processes because their inflammatory process is critical for our survival. So, activation of these systems has to be efficient. With these three systems interacting, the entire inflammatory response may be activated. Also, the mediators that are released that we talked about earlier during the inflammatory response are very potent and they can be potentially harmful. So, their actions must be controlled and confined to only the tissues that are damaged. There are multiple gatekeepers that regulate these plasma protein systems, the activation or inactivation of the reactions to maintain balance. These mechanisms control or contain the inflammatory response. An example of this would be the fibrinolytic system. This system will control the size of the clot and degrade the clot after the bleeding has ceased. There are other mechanisms that control different parts of the inflammation process. You can look them over on page 139 of your text. Cells that are in the innate and adaptive immune systems respond to molecules that are hanging around the site of cellular damage. They go to that site to help with the protective response that we just talked about. These molecules can come from destroyed or damaged cells, microorganisms that are there, maybe activation of one of the plasma protein systems, or secretions by other cells. Each cell has a receptor on its surface. Remember we talked about receptors in a previous chapter, and these receptors are going to specifically bind to these molecules. This results in a signaling and activation of the cell itself. These cells will then act at the site of injury to confine the extent of damage, kill the microorganisms, remove cellular debris, and activate healing. These cells are known as mast cells, endothelial cells, platelets, phagocytes, which are neutrophils and macrophage, and lymphocytes. These are all very critical components of an effective innate immune response. Further in the lecture, we're going to get into the individual cells and what they do. Getting a little bit more into depth into these receptors, they are referred to as PRRs, or pattern recognition receptors. They recognize the molecule they're looking for. They're expressed on cells in the tissues near the body surfaces, like for instance the skin, the respiratory tract, or the GI tract. They are continually monitoring the environment for products of cellular damage or infectious microorganisms, and they are trained to recognize the two types of molecular patterns that they're looking for. The first type of molecular pattern they're looking for is called a PAMP, pathogen-associated molecular pattern. These are molecules that are usually expressed by infectious agent. They're either located on the pathogen's surface or released from the pathogen. DAMPs, or damage-associated molecular patterns, are products of cellular damage alone. So the damage has been done and the receptors recognize the molecules that result. So different cells with different receptors are looking for these PAMPs and DAMPs. Some cells have what's called toll-like receptors. These can recognize a large variety of PAMPs that are located on cell walls or surfaces of the microorganisms. C-type lectin receptors can bind both PAMPs and DAMPs, so they can recognize both. And these are important when we talk about fungus and those antigens. Nod-like receptors help to control the inflammatory response. And scavenger receptors are expressed primarily on macrophage. With any process, communication is imperative to success. So how do the cells communicate? In come cytokines. Cytokines are intracellular signaling molecules. They're secreted by many types of cells to bind to specific receptors where they work to regulate any part of the immunity. Cytokines can be pro-inflammatory or anti-inflammatory. It depends on if they bring on the inflammatory response or if they're trying to stop the inflammatory response. They've been classified into several different families, and it's based on their structural differences. Lymphokines and monokines are types of cytokines that come from lymphocytes or monocytes, which are types of white blood cells. Chemokines are a special cytokine that attract leukocytes to the site of inflammation through chemotaxis. So to remember that, I think of taxi in that word. It's bringing or attracting the cells over to where it needs to be. Interleukins are a special type of cytokine. These are produced by macrophage and lymphocytes, and they respond to stimulation of receptors or respond to other cytokines. They essentially communicate changes in the behaviors of the cells. They assist in cell adhesions, they attract leukocytes to the site of inflammation during chemotaxis, and they assist with the making of leukocytes in bone marrow. Generally, they can help suppress the inflammation response and adaptive immune response. Other types of cytokines are pro-inflammatory or communicate inflammation to the cells. Tumor necrosis factor alpha, or TNFA, is one of the most important cytokines. It's important to know that TNFA plays a response to virtually any injury or infection. It also contributes to the damaging effects of chronic inflammation on the body. TNFA can have systemic effects, including bringing on a fever, assisting in the process of muscle wasting, and causing intravascular thrombosis. TNFA interacts with two interleukins, IL-1 and IL-6. These are also pro-inflammatory. IL-1 is produced by macrophage and enhances innate and adaptive immunity. It's also known as an endogenous pyrogen, or fever-causing cytokine. It does this by acting on the receptors of the cells of the hypothalamus, causing a fever. IL-6 is also produced by macrophage, but it can also be produced by lymphocytes, fibroblasts, and other cells. This cytokine directly induces hepatocytes in the liver to make proteins that are needed for inflammation. It also stimulates growth of blood cells in the bone marrow and growth of fibroblasts that are required for wound healing. High levels of these can be lethal. Pro-inflammatory cytokines themselves can be lethal. On the flip side of this are the anti-inflammatory cytokines. They are the anti-inflammatory communicators. Two of the most important of these are interleukin 10 and TGF-B. Interleukin 10 is produced by lymphocytes. It limits the production of pro-inflammatory cytokines by the macrophage. TGF-B is produced in response to inflammation. It's going to suppress the activity of lymphocytes and staunch the production of cytokines by macrophage. Similar to pro-inflammatory cytokines, though, high levels of these anti-inflammatory cytokines can also be lethal. Another type of cytokine is an interferon. These are pretty unique. They help modulate the immune response and protect against viral infections. They are very essential to both innate and adaptive immunity. One type of interferon is produced and released by virally infected cells. These do not kill viruses, rather, they induce viral proteins or antiviral proteins and protect the cells that are healthy. Type 2 are produced by lymphocytes. These activate macrophage and help increase their ability to detect invaders so they can be removed by our adaptive immune system. So we're still talking about the cellular components of inflammation. We just went over cytokines. Mast cells are another component. They're significant and potent activators of our inflammatory response. As you can see in the picture, they have abundant granules that contain biochemical mediators. These are released if there's a tissue injury. When there's a tissue injury, mast cells release substances that are important for our inflammation response. One way they initiate the inflammatory response is to degranulate. Within seconds of a tissue injury, mast cells will release their granules that you see into the surrounding tissue. These granules contain histamine, chemotactic factor, and cytokine. The second way is synthesis. When mast cells are activated, they initiate the synthesis of other mediators of inflammation, which we're going to talk about on the following slides. Just a little bit more about degranulation. Again, this happens within seconds of an injury. As mentioned in the previous slide, these granules include histamine, chemotactic factors, and cytokine. So what do we know about these things from this lecture? Histamine vasodilates. Chemotactic factors attract or repel, and cytokines communicate, all important parts of the inflammatory process. So in this picture, you can see the mast cell. On the left, it shows degranulation, and on the right, it shows synthesis. So with the degranulation, you can see the chemotactic factors. They're attracting white blood cells. The histamine, which produces the vascular effects of vasodilation. And the cytokines are being released. In this case, they are pro-inflammatory communicators. On the synthesis side, you can see the enzyme being released that initiates synthesis. This eventually produces the mediator leukotrienes and prostaglandins. In the red box, you can see that leukotrienes have a vascular effect, and prostaglandins have an effect on pain. So getting just a little bit more into depth on this, you saw in the picture with degranulation, the granules contain the different substances, one of them being histamine. Histamine is a small molecular weight molecule and has a potent effect on other cells, especially those that control the circulation. Histamine is going to bind to certain receptors known as H1 and H2. H1 is pro-inflammatory and H2 is generally anti-inflammatory. Histamine is also known as a vasoactive amine, which means it causes a rapid, temporary constriction of smooth muscle. It's going to cause increased blood flow into the microcirculation and vascular permeability, meaning those vessels will be permeable because the endothelial cells retract and they become leaky, spaces in between, so big molecules can get through. This is the basis of an allergic reaction, though. If someone takes an antihistamine, that drug blocks the binding of the histamine to its receptors, and there are going to be decreased vascular effects then. H1 receptors are also present on smooth muscle cells, especially in the bronchi. So H1 stimulation in this area causes bronchoconstriction, which is seen in asthma. H2 receptors, again, are anti-inflammatory in nature because they suppress leukocyte function. These are commonly found in the parietal cells of the stomach mucosa. Stimulation of these causes secretion of stomach acid. This is usually a normal body function. We need stomach acid to break down our foods. But if someone is taking like an H2 blocker like Pepcid, this is going to reduce gastric acidity because it's going to block the production of acid. If we remember, then we saw in the picture that in degranulation, along with the histamine, chemotactic factors are released. These cytokines attract. This involves neutrophil chemotactic factor, or NCF, and eosinophil chemotactic factor of anaphylaxis, or ECFA. Neutrophils destroy bacteria in the early stages of inflammation, and eosinophils help regulate the inflammatory response. If you remember the picture of the mast cell not only had degranulation on the one side, but synthesis of mediators on the other. As I said, this is a release of an enzyme that activates a process to produce leukotrienes and prostaglandins. Again, leukotrienes have a vascular effect, and prostaglandins affect pain. Leukotrienes are known as a slow reacting substance of anaphylaxis. They induce smooth muscle contraction, especially in bronchoconstriction. These are similar to histamines, but they stimulate slower and have a more prolonged inflammatory response. They are not quick like histamines. Prostaglandins can increase vascular permeability, neutrophil chemotaxis, and pain. When someone takes an aspirin or NSAIDs like Motrin or Advil, this blocks the making of prostaglandins and therefore stopping the inflammation and pain. It's important to remember to be careful when taking NSAIDs. Blocking this process can have a bad side effect on the GI system. Using too many or taking them without food blocks the prostaglandins in our GI system that helps with mucus production. This can cause GI bleeding and ulcers. Another cellular component of inflammation are endothelial cells. We've been talking a lot about these. These line our blood vessels. They regulate circulation through the microvessels. They control the movement of water between blood and tissues and maintain normal blood flow. They do play a large part in inflammation. Damage to the cell lining of the vessel is going to initiate activation of platelets, call for the leukocytes, and begin the facilitation of wound healing. Platelets. Speaking of platelets, these are a part of our inflammation process, but these are special in that they do not contain any nucleus. They circulate in the bloodstream until they're activated by an injury of the vascular system. These are usually called by collagen or thrombin, which are byproducts of tissue destruction and inflammation. They also help the coagulation cascade by helping to stop the bleeding, if you'll remember. Platelets will also degranulate and release biochemical mediators like serotonin. The effects of the serotonin is similar to the effects of the histamine on the blood vessels. Platelets can also kill pathogens and release growth factors that promote wound healing. Neutrophils. These are named after their staining pattern in a microscope. It has a multi-lobed nucleus. They are the predominant phagocyte in early inflammation, meaning that they ingest. They usually arrive between 6 to 12 hours after the initial injury, but know that they are the first ones there with the job of killing bacteria and preventing infection. Inflammatory mediators like bacterial proteins and complement fragments attract and activate these circulating neutrophils in the blood. Their primary role is to phagocytize pathogens, remove cellular debris and dead cells from the area of damage. Neutrophils are mature and incapable of division, and they're very sensitive to the acidic environment that is found at the inflammatory sites. Because of this, they're short-lived and they become a component of pus or purulent exudate, which is removed through the skin or drained from the infection. Eosinophils, these are another type of granulocyte. They are somewhat phagocytic, meaning that they ingest, and they are another primary defense in the body against parasites. They regulate vascular mediators released from mast cells like histamine. That means that eosinophils play a very important part in allergic conditions and can contribute to tissue damage. Basophils are the least prevalent granulocyte in the blood. The contents of its granulars are similar to mast cells. Not only do they release histamine, but they contain heparin as a natural occurring anticoagulation product. Basophils are an important source of cytokines that are involved in the adaptive immune response, particularly in responses associated with allergies and asthma. Monocytes are the largest white blood cells. Just like other blood cell types, they are produced in the bone marrow and they enter into circulation. Monocytes go to the site of inflammation where they transform into macrophage. Monocytes build specific tissue macrophage. They are precursors to liver, lung, and brain cells. Macrophages that come from monocytes will usually arrive at the inflammatory site around 24 hours after the neutrophils, but they don't arrive in big numbers until about 3 to 7 days later. There are two subpopulations of macrophage, M1 and M2. M1 kill more bacteria, where M2 are involved in tissue healing and repair. Macrophages actually do well in an acidic environment at the inflammatory site. So you can imagine then that they work longer on damaged cells. They play a big role in removing debris, forming new blood vessels, which is called angiogenesis, and secrete growth factors that prepare the tissue for healing. You got to think of them as the resolution of inflammation. Be aware, however, that there's some bacteria that can survive inside macrophage. Bacteria that causes leprosy, typhoid fever, listeriosis, they can remain dormant or multiply inside of macrophage. Dendritic cells. This is another cellular component of inflammation. These provide a link between innate and adaptive immune responses. They're phagocytic, meaning they ingest, and they're located in peripheral organs and skin. They recognize pathogens through their receptors. The invaders are then internalized within the cell through phagocytosis, which means that the dendritic cell eats the invader. They are then going to migrate through the lymph system to the lymph nodes, where they present the invader like a trophy to our T lymphocytes. This results in an adaptive immune response, which we'll get into more in another chapter. The last components of cellular inflammation are lymphocytes and natural killer cells. Lymphocytes are a type of white blood cell. They activate macrophage and they initiate a specific protective immune response against pathogens and cancer. B lymphocytes produce antibodies, and T lymphocytes regulate other immune cells and kill viruses and cancer cells. Natural killer cells are a type of lymphocyte. They eliminate virally infected and cancerous cells. Natural killer cells bind to target cells through activating receptors. They produce cytokines and other toxic molecules, which will in turn kill the target cell. Their receptors can't tell the difference between affected and normal cells. So in this lecture, I've mentioned phagocytosis a couple times. This is essentially the ingestion of foreign particles or cell fragments. This is usually the job of the neutrophils and the macrophage. Remember that neutrophils circulate in the blood in big numbers, and they release chemotactic factors. Remember the communication part. They attract them to the area of injury. Activated neutrophils are going to express adhesion molecules. This makes cells sticky, and it causes the neutrophil to stick to the endothelial cell wall of the capillaries and the venules. This is called margination or pavementing. Once the neutrophils are stuck to the endothelial cell wall, diapedesis will result, meaning that the endothelial cell retracts and phagocytes move through that basement membrane at those junctions and into the tissues. So basically, it's expanding and making room for those phagocytes to move through. When the phagocyte moves through and gets to the inflammatory site, phagocytosis, or eating of the damaged cells and invaders, begins. Let's go through the steps of phagocytosis. First, the phagocyte has to recognize and adhere to its target through the receptors. It's going to ingest or engulf the bacteria and become what's called a phagosome. The phagosome then fuses with lysosomal granules or enzymes within the phagocyte. The phagocyte then destroys the target. Within the membrane-bound vesicles, there are digestive enzymes that protect the phagocyte from harm. When phagocytes die, they cause tissue damage at the site of inflammation. When it dies, it's going to break open or lyse. This causes the release of enzymes into the tissue, and these enzymes can then cause tissue destruction. However, the good news is this is minimized by natural inhibitors found in the blood. We have a mechanism that protects us from that. Okay, so hang in there with me. We got through some of the tough stuff. I want to talk about the different types of inflammation, acute and chronic. Acute inflammation is defined as self-limiting. It's usually only about 8 to 10 days, keeping in mind this is the length of the process from the onset of injury to the actual healing. If it proves to be inadequate, chronic inflammation may take over, and that leads into weeks or months of inflammation. The characteristics of these two responses differ. They both involve different biochemical mediators and cells that function together in a coordinated manner. If there is success in containing the damage and infection within the tissue, both of these responses will hopefully lead to healing. So some of the characteristics of acute inflammation are local swelling, pain, heat, redness, and for some injuries, loss of function. These are results of the cellular and vascular changes we talked about. Exudative fluids will result from higher permeability in the vasculature and the leaking of the fluid into the tissues. In very early acute inflammation, exudate is usually serous, meaning it's watery. It'll have very few plasma proteins or white blood cells. An example of this would be a blister. In more severe or advanced inflammation, there may be fibrinous exudate, which is thick and clotted. An example of this would be the fluid in the lungs from pneumonia. As mentioned earlier, there is also purulent exudate or pus. This is an accumulation of a large number of leukocytes, which we see in cysts and abscesses. And when there is bleeding, the exudate is filled with erythrocytes and described as hemorrhagic exudate. With acute inflammation, there may be systemic or whole body manifestations. This includes fever, leukocytosis, which is an increase of white blood cells, or a showing of increased circulating plasma proteins. Let's talk about fever first. It's usually induced by cytokines, as we said, TNF-A and IL-1. These cytokines are released from neutrophils and macrophage, and they are known as endogenous pyrogens, or causing fever. These are different from exogenous pyrogens because those are usually produced from pathogens. Pyrogens in general act on the hypothalamus, the thermostat of the body. So know here that fever can be kind of beneficial because microorganisms are very sensitive to increases in body temperature. Leukocytosis. This is another systemic manifestation of acute inflammation. These are circulating white blood cells that are very high. The upper normal is 11,000 microliters of blood, of white blood cells in the blood, so much higher than that. When there's an infection present, something called a shift to the left may happen. So what that is indicating is that there's a ratio that is higher of immature to mature neutrophils. Inflammation is going to stimulate release of granulocytes and monocytes from the bone marrow, and these cells are all going to migrate into the blood circulation to move to the site of inflammation. That not only increases the number of leukocytes, but increases the ratio of immature to mature cells. If there's an increase in the number of white blood cells in combination with that abnormal differential count, that is the shift to the left. It could indicate infection. Basically, the body is putting out immature white blood cells because it's trying very hard to fight the infection. The last systemic response in acute inflammation is increased plasma protein synthesis. These plasma proteins are usually produced by the liver and are increased during inflammation. They can be pro-inflammatory or anti-inflammatory, but they're usually referred to as acute phase reactants. These reach a maximum level within 10 to 40 hours after the onset of inflammation. So the increase here is usually in fibrinogen, and that's associated with an adhesiveness of the erythrocytes. So basically, with this fibrinogen increase, the erythrocytes start to stick together and they form clumps. So when someone takes what's called a sed rate or a erythrocyte sedimentation rate, these are very slow to settle in a test tube. They're too sticky and they're too big and they're buoyant, so they're slow to settle into the bottom of the test tube. And that's going to give an increased value in the laboratory test. That can indicate that the inflammatory process is going on in the body because it's increased. Another lab measure of inflammation is called a CRP, or cross-reactive protein. This is also increased during inflammation. So here's a quick question. An injury to a vascularized tissue has occurred and activated an acute inflammatory response. Which of the following is true? It's nonspecific, it's activated slowly, it's the third line of defense, or it relies on cellular components only. So the answer is A. It occurs at the site of tissue injury and it's very nonspecific. Remember, I said that it happens the same way no matter how many times we get a splinter, the inflammatory response happens the same way every time. It is very quick, it's activated within seconds, and it's considered our second line of defense. And obviously, it relies on many cellular and chemical components that we've talked about in this lecture. So let's talk a little bit about chronic inflammation. Looking at it simply, it's longer. It usually lasts 2 weeks regardless of its cause, and sometimes it begins with unsuccessful acute inflammation. In an example, if there's a bacterial contamination or foreign objects like dirt, wood, glass, an acute response may then go beyond the 2 weeks. In this case, there will be formation of pus, discharge, and incomplete healing. Chronic inflammation, though, does not always have to start with an acute inflammation process. Chronic diseases have a component of chronic inflammation. Even if the reason for the inflammatory responses is unknown, there are chronic conditions that express chronic inflammation. Autoimmune diseases and chronic infection are just a few of these. Other causes of chronic inflammation are when pathogens or microorganisms are resistant to the acute phase of inflammation, or they produce toxins that cause damage in the tissue. In chronic inflammation, lymphocytes and macrophages pack in. If macrophages are unable to protect the body from the tissue damage, the body forms a granuloma. This is an attempt to wall off and isolate the infected area. Infections that are caused by bacteria, parasites, and fungus will commonly result in granuloma formation. You may also see granulomas around foreign bodies that are not removed from the tissue. You may see these around things like G tubes for those who have them who receive enteral nutrition. We talked about how macrophages are called into the area of inflammation. Sometimes these macrophages turn into epithelioid cells. They specialize in taking up debris and small particles. Other macrophages may turn into multinucleated giant cells, which in essence are active phagocytes. They pick up much larger debris. Epithelioid cells and multinucleated giant cells make up the center of the granuloma, and then they are surrounded by the lymphocytes. In the last part of this lecture, we're going to discuss wound healing. This is the conclusion of inflammation. Obviously, we want to return to normal structure and function. If there is only a minor damage to the area, complete healing may occur. Sometimes tissues can regenerate. This is when destroyed tissues are replaced with healthy tissues of the same type. We'll see regeneration in the epithelium of the skin, in the intestines, and in the organs like the liver. This is called resolution or maturation. Surprisingly, this process can take up to 2 years. Resolution does not always happen though, and it may not be possible if there are large amounts of damage. This usually happens if the tissue is not capable of regeneration, where an abscess or granuloma may have formed, or if fibrin persists in the lesion. When resolution is impossible, repair comes into play. That's when the original tissue is replaced with scar tissue. Scar tissue is composed of primarily collagen. That collagen fills the lesion, restoring integrity and strength of the tissue. But what collagen does not do is carry out the function the previous tissue had. Scar tissue can result in the loss of function. Wounds like paper cuts, surgical sites, or other clean incisions will be healed through the process of primary intention. Because there's minimal tissue loss and close approximation of the edges, healing is going to occur quickly. Other wounds, like severe burns or open wounds, are going to require a great deal of tissue replacement. These heal with what's called secondary intention. Both of these processes happen at different rates depending on the location and type of the tissue. There are 4 types of wound healing. The first phase is hemostasis or coagulation. Tissue damage is going to cause bleeding into the wound. Damaged blood vessels will immediately constrict and then dilate. The coagulation cascade is initiated and there's an activation of platelets. The fibrin mesh of the clot sets the stage for cell rebuilding and healing. Platelets contribute to the clot forming too. They begin to degranulate and release factors that are going to help with permeating the capillaries and initiate the growth of healthy cells. Here, there's also activation of complement and kinins, which we talked about earlier, the plasma protein systems. Phase 2 of wound healing is the inflammation stage. This is what we've been talking about in lecture. Macrophage and mast cells release cytokine that affect the vasculature, increase blood flow to the wound, and bring needed cells and proteins to the injury. Neutrophils then fill the area of injury and start clearing the wound of debris and bacteria. Lymphocytes initiate an immune response here. 3 to 4 days after the injury, then, proliferation begins, stage 3. This can continue for as long as 2 weeks. This is when the wound is sealed and the fibrin clot is replaced by scar tissue or normal tissue if there's minimal damage. This stage is when the macrophage cells invade. Macrophages are essential to later wound healing. They clear more debris, they release growth factors, they bring in fibroblasts and promote the making of collagen. They also begin angiogenesis, again, which is the formation of new blood vessels. This is when a scab is formed or there is dissolution of fibrin clots. This is also known as debridement. After debridement, remaining debris is drained away by blood and lymph, and any dilation of the vessels or more permeability of the capillaries is then reversed. This is preparing the lesion for either regeneration or repair. As wound healing further progresses, the granulation tissue will grow into the wound. This is coming from the connective tissue. This granulation tissue will have a red and granular appearance. Young, fragile capillaries begin to form. These capillaries will turn into larger vessels as repair continues. It brings in more nutrients and removes metabolic wastes. Also, lymphatic vessels will grow by a similar process. Epithelialization is when epithelial cells grow into the wound from surrounding tissues. This process can be quicker if the wound is kept moist to prevent the fibrin clot from becoming a scab. Finally, in phase 4, there is tissue remodeling and maturation. This usually begins several weeks after the injury, and as I mentioned previously, it is completed within 2 years. Tissue regeneration continues. Cells are going to change and mature. Scars will form and scar remodeling will take place. Fibroblasts are important here as they're a major cell involved in tissue remodeling and rebuilding. They deposit collagen in an organized matrix. So on the left here, you can see wound healing by primary intention. Again, there's minimal tissue loss. The edges are close together. There's a close approximation. You can see the phases. Hemostasis, the fibrin clot is there. The platelets are rushing in. Inflammation begins when the neutrophils come in to do the dirty work of clearing away the debris and bacteria. Then the next stage you can see proliferation 3 to 14 days later. Macrophage come in to continue the cleanup. This is also when granulation and new epithelial cells start to form from the surrounding tissue. Angiogenesis is here. New vessels are forming. Lastly, you can see remodeling, fibroblasts depositing collagen to build scar tissue. On the right, you can see secondary intestine goes through the same process, but on a much larger scale. Lastly, I just want to touch on what happens when wound healing goes wrong. If there's evidence of ischemia or if the tissues are oxygen deprived, they are very vulnerable to continued injury and cell death. This prolongs inflammation and delays healing. Lack of oxygen equals low energy production and impairs collagen. Also, if there's excessive bleeding in the wound, there may be delayed healing. Large clots leave bigger spaces to fill. Large clots also block oxygen. Where there's accumulated blood, there's accumulated bacteria. We know that bacteria can cause infection and can prolong inflammation due to there being more pus. Usually vessels will dilate, delivering nutrients and oxygen to the site of the injury. But if there is decreased blood volume that is associated with bleeding, it could inhibit inflammation because the vessels need to constrict to stop the bleeding. If there's too much fibrin, this can also be a detriment to healing. Fibrin that is released is eventually reabsorbed to prevent adhesions. If there's too much fibrin, especially in places like the abdominal cavity, adhesions can form and bind together, making large fibrous bands. These bands can distort, impinge, strangulate, and affect organs. Adhesions may bind one organ to another, which could cause pain or impaired organ function. We also need to consider predisposing disorders that would affect wound healing. Obesity can impair leukocyte function, which predisposes wounds to infection. Also with obesity, there is dysregulation of collagen synthesis and a decrease in angiogenesis. Those who have diabetes are also at risk for prolonged wound healing and wound infection, especially if they have persistent hyperglycemia or high blood sugar. Those with diabetes tend to have ischemic wounds due to small vessel diseases and impaired blood flow. If that person has hyperglycemia, it increases the level of glycosated hemoglobin, meaning that it loves more oxygen. Tightly bound oxygen is not as readily released into the tissues. If there's an infection of the wound due to the presence of pathogens, there are subsequent destruction of the cells. If a person does not have good nutrition, in all phases of healing are then going to be affected. This is due to the increased metabolic needs of the tissues. If there are deficiencies in vitamins like A and C, for example, collagen may not be formed correctly, and therefore connective tissue is also poorly formed, significantly impairing healing. Medications like NSAIDs, steroids, and anti-neoplastic or cancer drugs can cause dysfunctional wound healing. NSAIDs suppress inflammation and inhibit prostaglandin production, delaying wound healing, especially involving bone tissue. NSAIDs have also been known to cause excessive scarring. Steroids can prevent macrophage from migrating to the site of the injury and inhibit fibroblast migration to the wound during the proliferative phase, which delays epithelialization. And anti-cancer drugs slow cell division and inhibit angiogenesis. Lastly, toxins like tobacco smoke, which is a mix of carbon monoxide and hydrogen cyanide, can delay wound healing. Nicotine causes vasoconstriction, which causes less oxygen to be delivered to the cells. If there is dysfunction in collagen synthesis, for example, if it's excessive, there may be formation of a keloid or hypertrophic scar. A hypertrophic scar is raised, but it remains within the boundaries of the wound, and it may get better over time. A keloid scar is also raised, but it goes beyond the original boundaries of the wound, and it invades surrounding tissues. It may even come back after surgical removal. Keloid scars tend to run in families and happen more often in people with darker skin pigmentation. Wound disruption can include dehiscence. This is when the wound pulls apart at a suture line after surgery. It can occur anywhere from 5 to 12 days after surgery typically. Over half of dehiscences are associated with wound infection.